take a look at some of the training objectives. These are some things that we'll try and touch on today. I'll move through the slides pretty quickly, but again, if you would like to unmute and make a comment, I would encourage that. But I also would say we can use the chat feature to also exchange some ideas. And I know Kate will help me monitor some of the chats coming in. It'll be hard for me to look at those while we go through the slides. So there's our training objectives. We'll look at some evidence-based practice. I want to also talk a little bit about the importance of creating that alliance with your patients during treatment and forging that rapport and relationship. And then we also will look at some commonly used evidence-based practices and approaches. I want to touch on some co-occurring disorders and the integration of substance use disorders and other parts of the care continuum. And then also I've added some slides on medicated assisted treatment as that has been a real important component of many of our outpatient and residential treatment facilities over the past 4, 5, 6 years. So hopefully we'll get a chance to touch upon each one of those. So let's jump right in. Let's look at evidence-based practice or evidence-based practices, best practices, and there are some other terms as well that we might keep in mind. One of them would be wisdom-based practice.
Excuse me, can you move your slides so we can see them?
Oh yeah, did I stop my screen share? Oh.
You haven't started.
Steve,
yeah, but I think I paused it.
I think you might be, you're sharing, we're actually just seeing where you have the PowerPoint open on the first slide, and we're seeing like the slide deck over on the side, and the
it looks like I paused my, it looks like I may have paused my there, how about that?
Okay, and then now you might want to also go up to the button at the top where it's like you see the the auto save and then the save button. That next button over to the right is like the share slideshow, and then we'll see it full screen.
Yes, there. Is that better?
There we go. Yeah.
Are you guys seeing that full screen, or?
We're seeing it with your notes too. So if there's I mean, that's not a big deal. I don't think you're worried about sharing your notes. But
let me see if I can adjust that though.
It might be an option to share your other screen, because I think the other screen is probably showing just the slide.
Yeah, I'm not sure why that. Let me try that. Let me try that again. Can you guys see that? Can you guys see that?
Yeah, we're seeing it still in like the editing mode.
Just go to slideshow.
Yes,
just go over to slideshow.
Yeah, I can't seem to
go to that.
I can't seem to get it out of that mode, Kate. I don't know what.
Okay, let me see if I can. Sorry about this.
That's all right. Here, let me get my screen share back up, and sorry about that. Let's just hang with me here. Try and share.
When it was showing the notes, on the very top it said display settings. If you down click on that arrow, you should be able to switch the view so it doesn't show the notes.
Yeah, I don't know why it won't.
At the very top, display settings.
Oh yeah.
And then you should be able to switch it to the next screen.
There.
There we go.
Is that better?
Thank you.
Is that better?
Yes, that's better.
Oh, sorry about that. I do have my screen up so I can see my notes. So that's great. Sorry about that. So again, let's look at some evidence-based practice and best practices. there are other terms I want you to keep in mind as we're going through this. Some of them may be familiar to you, things like wisdom-based practice or experience-based practice or promising practices. Are there other terms that that you guys are familiar with? Maybe other terms that you would use when describing evidence-based practices? Throw those in the chat. We can come back to them maybe. So evidence-based practice, evidence-based best and promising practices. So again, this is just more of a review. For some of you, these are terms that we are very familiar with. But evidence-based practices are these methods or techniques that have been have these documented outcomes, and they've been able to replicate these and have been recognized in scientific journals, and really recognized in sort of that Western sort of medicine approach. But again, they really oftentimes are tied to funding and are really seen as supported, empirically supported approaches. Best practices, these are shown to again have some consistency and some better results than other means, but the best practice hopefully would evolve into an evidence-based practice or approach. Promising practices, again, here we have this idea that there's a body of evidence that really is leaning towards the likelihood that this may be a practice that will be endorsed or supported through empirical research or data. Other practices like wisdom-based or experience-based, I think, are really oftentimes based on thousands of years of practice or application in history, and we see that play out in various cultures. And I know that, for example, in Native culture, wisdom-based practices are really founded on thousands of years of implementing healing practices and other treatment approaches. They're just simply not acknowledged and aren't supported by this empirical data. So let's keep going. I want to look at the characteristics of substance use disorders, and this I know it says addiction, but that's a term that I'm going to move away from, and I would encourage all of you to move away from that term addiction. It does have its time and place, but it has really been removed from a lot of the literature, and really the term has been removed from DSM-5. But I want us to think of it as the characteristics of substance use disorder. And some of the things that we'll look at are the American Society for Addiction Medicine. This is a set of criterion used to help describe substance use disorders and monitor progress, and it's also used in the process of treatment placement and ongoing monitoring of progress. And I'm sure many of you are familiar with this term or with this concept, the ASAM criterion. It's been around for several decades and has evolved over time. An inability to consistently abstain, impairment in behavioral control, craving, diminished recognition of significant problems with behaviors, and interpersonal relationships, and a dysfunctional emotional response. This is sort of a classic definition of substance use disorder. And there are a few others, and this terminology continues to evolve, and moving away from some of the stigma associated with the term addiction and how it affects impacts one's life and the people around them. So one of the things that we'll look at, I'm going to move this screen down here. Let's see if I can get this set up a little bit better. I even have multiple screens and I'm still having a hard time moving things around here. So our goals for treating substance use disorders and co-occurring disorders. Really, one of the primary goals is to properly assess the patient's using a multi-dimensional tool. And I think this is important because, as we know, there are many layers to a person's substance use, as well as any comorbid or co-occurring or underlying disorders. And we'll circle back to that concept later in the slide presentation. Also, one of the goals is to provide an integrated, coordinated sort of continuum of care using, whenever possible, using evidence-based practices or approaches. We see this play out in the use of things like motivational interviewing or stages of change and other or motivational enhancement therapy. Practices that have been proven over time to be effective and have positive outcomes. To provide an optimum opportunity for healthy behavior change through this therapeutic alliance. And again, that therapeutic alliance is something that I want to touch again on as we talk a little bit about rapport building and connecting with our patients in that therapeutic dyad. Also, just to keep in mind, just to improve the patient's overall health and wellness. And we're gonna revisit this topic several times, but just as to tip my hand a little bit, when we're talking about treating a patient with a substance use disorder, I really want you to think of their substance use, whether it be a narcotic or cannabis or alcohol or any combination. Think of that really as a symptom. Think of their substance use as a symptom, that it's not the problem. It's causing problems, but it's not the problem. It's symptomatic to some other underlying, perhaps pre-existing conditions. Keep this in mind because we're going to come back to that. And then obviously to measure outcomes. I used to oftentimes have families or referrals say, well, what's your success rate at your clinic? And that's a very difficult question to answer because success can mean one thing to one person and something else to another. We know that substance use disorders are very, very difficult to treat, and really the psychological component to substance use disorders is far more complex than treating the physical components to a substance use disorder. But to have measurable outcomes, to be able to follow up and see the impact of treating someone with a substance use disorder and or a co-occurring disorder is important. And then also to provide informed consent. I think that's also one of the goals for treating substance use disorders and co-occurring disorders. And then lastly, to think of this sort of under this umbrella, not only the biopsychosocial umbrella, but to think of one of the goals is this sort of this ROSC concept, this recovery-oriented system of care, where you have multiple layers of services and providers working in conjunction with one another to treat the whole patient from this holistic sort of biopsychosocial perspective. I hope that makes sense. Kate, do we have anything popping up in the chat that's noteworthy or anything we want to stop and talk about so far?
No big questions yet.
Okay.
Just a couple of logistical things that someone's asking about the recording and the slides, and I just want to let you all know that we are recording this, and in a few days we'll send out a link to the recording as well as handouts of the slides. So
yeah, that's great. So
I think that's all we've had so far.
Thank you, Kate. So let's think about and ask ourselves, these goals of treating substance use disorders or co-occurring or mental health disorders. What does this all mean? Well, we have a responsibility to improve service delivery and to really watch these patients and what they do in response to the treatment we're providing. The field of substance use disorder treatment is evolving and will require a broader understanding of the term treatment. It is evolving as we speak. 30 years ago, substance use disorder treatment centers were made up almost exclusively of individuals who were in recovery themselves, and they were almost exclusively sort of 12-step or disease model, or what we call Minnesota model oriented. And this has evolved immensely in the last 30 years. We could spend most of the slideshow talking about this. There's a nice mix now of both recovering and non-recovering clinicians in the field, which I think benefits the field overall. And the field has become recognized more as a profession. And the credentialing and some of the base requirements for providing services in the substance use field have increased as well, which again is a good thing for those of us in this line of work. So, and the other thing to keep in mind is we have a responsibility to stay informed about best practices and these promising practices. And I would add and offer the idea of keeping an open mind to wisdom-based and experience-based approaches and practices as well. And then those in the leadership positions have a responsibility to prepare and mentor the next generation of substance use disorder treatment professionals and behavioral health professionals for entering the field and treating the patients that desperately need our guidance and care. Well, that one's kind of low on me there. Let's look at, let's look at the therapeutic relationship. I'm gonna have to move that up a little bit. So let's look at the therapeutic relationship. So one of the things I want you to do, and this is again, this is an important concept, and I can share a couple of experiences regarding this, but the idea that the more we involve our patients in the decisions of the decisions about their treatment process and what will happen to them, the more meaning and purpose they will likely attach or associate with that treatment experience. So one of the experiences I can share was I had a young man I was working with who was very disempowered, was in a group home, and first 3 sessions we had, he spoke very little and looked at the floor most of the time. And about the 4th session, his probation officer was putting some pressure on us to get a urine sample and to do some other things outside of just working with me at the clinic. And we were in my office, and at one point, we were talking about getting a urine sample to sort of placate his probation officer, and we were talking a little bit, and I said, "What do you think we should do?" And he looked up at me for the first time and sort of seemed moved by this question, and he said, "No one has asked me what I think we should do." And it was just this moment where it really became evident to me how important it is that we empower the patients that we have to be involved in the decisions about their own treatment. And I just wanted to share that, and we went on to have some really good sessions, and I found out a lot about this young man simply by engaging him and involving him in the decision process about what was going to happen to him. So really changing his sort of locus of control and really engaging him and empowering him to be part of the decision-making process. Very important. So this therapeutic relationship, this therapeutic alliance, if we want to call it that, this collaboration, if you will, developing rapport, common or shared goals, really creating a place of safety and trust. I can't stress how important this is, especially with many of the patients that, at least the patients that I worked with, oftentimes brought with them trauma, grief and loss, and other issues related to this. So creating an environment that is safe and that they feel like they can share and be open without fear of reprisal or punishment or having their privacy invaded. Very, very important. There's some ethical responsibilities connected to this, and power distribution. And I really want you to think of this, and I know many of you probably have experienced this, but the power distribution for me was always, I was trained to sort of flatten the relationship so that we were sort of on an even playing field. And I would often say to patients, you're the expert on your own life, and I'm here to guide and to be part of the solution. But really, this is about what you want to do and where you want to go. And this flattens the relationship and really puts the onus and the power back in the hands of the patient. Does this work all the time, just as you planned? No. But flattening the relationship can open doors for that rapport and that connection that cannot be replicated without that. So think about the therapeutic relationship and its function. So, I like to think of the term unconditional positive regard. And that's something that I think always sort of was sort of an overshadow or an umbrella of all of the work that I would do with patients. But positive reinforcement, encouragement, instill hope, and then build that sense of self-efficacy. Motivational interviewing, for example, really at its heart and in the spirit of that is to empower the patient to make decisions and to be the one, deciding on where we go from here. Providing the patient with support and accurate, genuine empathy, and then having this collaboration or this partnership, developing goals that are realistic and attainable and adaptable, using that model for developing those goals, the SMART goals, or I think there's some other acronyms that people have utilized. But really using that collaboration and connection with the patient to help develop their goals. And then also to model adaptive interpersonal functioning. So, and I think this is important. Sometimes showing the patient what it looks like to have a healthy, functional, interpersonal relationship in that therapeutic alliance. Also, the therapeutic relationship, as far as patient development goes, the patient feeling heard, understood and accepted, respected and empowered. I mean, that's a lot to attain, but you might have components of this that would be represented in that therapeutic relationship and that collaboration. Feels that the therapist is concerned, feels the therapist or clinician is working with him or her, working with, not telling them what to do or being very directive. The old sort of approach was very confrontational. You're a drug addict and you have to, complete this program the way I want you to, or you will not graduate from this program. That was sort of that old sort of approach. And now really it's, I oftentimes would ask a patient, tell me what it is that you like about smoking marijuana. Tell me what it is that alcohol, why has alcohol been so important to you over the years? That gives that sense that I'm working with them, I'm interested and concerned. I'm not condoning their use, but I'm also not demonizing. I'm trying to understand, and what am I doing? By asking a question like this, I'm really trying to look at what's underneath. Remember, patient substance use, it's symptomatic. So my goal sometimes as a clinician is to help explore and understand what's behind that, what's driving the substance use. And we could talk a lot about that as well. Feels the therapist is realistically optimistic, and I think that's important so that you don't appear disingenuous or too Pollyanna. I mean, you want to have some realistic optimism when connecting with patients, and then just also feels recognized that positive change is possible, or that it's occurring. The change is happening. Sometimes I would say in developing treatment plans, we would add the word to continue. So it wasn't something they needed to start, but maybe something they had already started, and we just want to continue that. Very important use of language and how that can empower a patient that change is possible. I want to look just briefly at the assessment portion. The substance abuse evaluation or mental health evaluation or that sort of comprehensive evaluation process is absolutely at the heart of everything that we do with the patient. Without that assessment, you're really flying blind. Without that assessment, you really aren't able to understand and design or be part of the solution for the patient, because you really don't know what it is that is affecting them. So the assessment is absolutely crucial, and the assessment needs to be something that is that has some level of continuity, that has some level of consistency, and allows for a comprehensive sort of conduit to gather information from that patient to help you guide them in making some adjustments or changes. So one of the components that we use, and I know some of you are familiar with American Society for Addiction Medicine criterion. The third edition of this, Dr. David Mealy is sort of the creator or the guru, if you will, behind ASAM, and it has evolved over the years. It was first introduced early in this form in the 80s, and has evolved steadily since then. But it's clinically driven, not program driven, and that's very important. If you have a 4-week intensive outpatient program and your patient is responding very well to treatment services, is making changes, is stable, they can complete that 4-week program in 2 weeks and be stepped down into a continuing care setting. On the contrary, and this would be supported again through ASAM criterion. This ASAM criterion, as you know, is based on a 0 to 4 risk rating scale. On the contrary, if a patient is struggling, having difficulty making appointments, having difficulty providing urine screening that is negative or evidencing that they are not actively using, you may extend that 4-week intensive outpatient program to 5, 6, 7 weeks. So clinically driven, not program driven. Also in this criterion, this ASAM criterion, and if we had time, I'd bring up a visual, but I'll show you on the next slide. You can kind of see the criterion themselves. The criterion do not involve a prescribed length of stay, as I mentioned, but promote a flexible continuum of care. They involve an interdisciplinary approach to care. In other words, it's not just me deciding everything. I'm involving numerous other providers or numerous other team members who may have their own area of expertise or specialty. This would also include an informed consent. They're outcome driven, and they also stress and clarify medical necessity. Very important. I'm going to assume that many of the listeners today know and understand ASAM, and you are utilizing this in their own practice. It's required by many states in order to receive compensation through third-party payers. So very important, and it really offers you an opportunity to defend and supplement your diagnoses your treatment approaches, and it offers a responsible way to monitor progress that's sort of universal or standardized. So I could call up Doc Foster there in Montana, and I could say, Doc, my patient is a 3 on a 0 to 4 risk rating in dimension 3, emotional, behavioral, and cognitive conditioning and complications. And Doc's going to know roughly what that means because he's familiar with ASAM criterion and how that impacts or affects the course of treatment or level of care assignment. But it really is it's a great way to you have a universal language amongst clinicians, especially in the addictions or substance use disorder field. Very important. But here's sort of a rundown of these 6 dimensions. Again, they are assigned to 0 to 4 risk rating, 0 meaning no risk or stable, and 4A or B meaning severe risk or acute disorder or acute condition. And I know they also have some, you can also rate these as mild, moderate, or severe to sort of line up with the DSM-5 language for assigning use disorders. So I want us to think again, put this under sort of the biopsychosocial umbrella. So biological, psychological, and social, but think about whole person or patient-centered care and really establishing this therapeutic alliance that we've talked about with the patient, and then making sure that starts from day one, right away. And then proper treatment requires proper assessment. Again, we've talked about this. Any good clinical agency is going to have a reliable, standardized assessment tool or series of tools that allow for clinicians to make responsible, appropriate recommendations that are easily defendable. I used to say to clinicians that I was training or managing or working with, would you rather defend why you recommended this level of care, or why you, would it be easier to defend why you recommended, let's say, residential services versus why you did not? And very important to have that those reliable assessment data to back up and support your recommendations. So proper treatment requires proper assessment. I think that's pretty self-explanatory. The ASAM can be a really vital supplement to any good assessment process. And again, having the multidisciplinary team approach, using community support systems, and using that ROSC model where it really is the village treating the patient rather than just a single person. And then selecting a particular theoretical approach that is most likely to result in the patient's improved health. And we know that, for example, in the substance use disorder field, I'm not saying that 12-step approaches don't have a time and a place, but if I'm going to treat the entire treatment population, we know that there's a segment of patients that are not ready to talk about long-term recovery. For whatever reason, they may not be there yet, diagnostically, or they may not have experienced enough adversity related to their use to be ready to talk about 12 steps or making a lifetime commitment to recovery, even if it's just one day at a time. But rather, we knew as a field that we had to adjust and make an adjustment to the way we approached patients. So having theoretical approaches that are more inclusive, that allow for some flexibility and adjustment, so that I could treat a patient who is not responsive or ready to engage in treatment just as readily as I could treat someone who is in an acute stage and very open to longer term recovery. I hope that makes sense. Again, I could speak quite a bit to this and how important it is to have a treatment approach whether it's adopted by your agency or your practice within your group of practitioners, that allows for you to adjust your therapeutic approach to where the patient is at, meeting the patient where they're at. Hope that makes sense.
It's Steve.
Yeah.
Can I jump in here too?
Of course.
Because we've had a couple of questions, and I wanted to make sure you know that Sean has joined too.
Oh, great.
And so he might be able to speak to a couple of these questions. So someone asked a while ago about examples of evidence-based practices that are effective with American Indian or Native American, Alaska Native patients. And then someone also just asked, why does MAT treatment have such a negative stigma in some tribes? And so, yeah, I'm curious if either you or Sean might be able to speak to some of that.
I certainly would turn the floor over to Sean to just address those. What was the last question? I missed. Why does what have such a negative?
Medication-assisted treatment.
Yeah.
Yep.
Yeah. Okay.
So I was trying to get Sean to unmute, but it might, I wonder if he's doesn't have an audio connection right now. So sorry, maybe we need to move on and try to come back to that.
We can circle back to that. I think there are some approaches in working with Native populations that can be culturally adapted. There are some traditional healing approaches that can also be blended with evidence-based or promising practices that, for example, you borrowing components of 12-step approaches using the Red Road or other approaches that borrow from traditional Western recovery models and blending them with Native approaches. I think there's some real promise in that, whether it's involving sweat lodge or other ceremonies. But again, I think Sean could probably speak more to that. And then as far as MAT, I think Native populations, as well as other portions of the populations, there's still a resistance to MAT and replacing one drug with another. I think that concept is, especially with some of the older generations, difficult to understand. And I think of it as, and try and use the example of, if I had a patient with diabetes and I knew that they needed a medication to have a quality of life and give them a chance to make some other adjustments and changes in their life, I wouldn't deny them that medication, and certainly would not stigmatize or ostracize them because of that. But I think there are some cultural implications that I think Sean could address, maybe privately in the chat, or if he wanted to reach out to him or myself, and I could forward those on to him.
It's not really being unknown, or not having the knowledge of it. It's a lot of that comes from the past, in a sense, which if you look at most medications today, about 70-some% of all medications actually come from traditional knowledge, indigenous knowledge around the world by indigenous peoples. Now, a lot of times what they do is they take these same medications, these same herbs, in a sense, and make them into a medication. Normally what happens, though, is they had to add fillers and stuff to actually add more problems. Earlier generations, what they had done is to look at what is going on within the past. Now, early in the past, they were giving people medications and stuff that actually did more harm to natives than it did to help them. One thing is when they were sterilizing women without their knowledge. So there's a lot of different things that are very important in remembering, because those things have happened in the past. Normally what happened is that if you look at the World Health Organization, is the way that they interpret traditional medicine is very different from traditional medicine from a native standpoint. Traditional medicine to the WHO is modern medication. From a native standpoint, traditional medicine is those herbs and such, because normally there's really isn't very many side effects at all compared to what medications do. Now, when they look at this, what happens is that they're looking at what they have taken, and when they've gone to the doctor, anything like that, they see it in a different form. And it's not traditional medicine as they have known it in their past. It's just very recently that more people are beginning to be more open to medication today than they were in the past. There are a lot more people who are more knowledgeable about the medications. And if you look at when MAT first came out, a lot of opiate problems, a lot of the natives were having a lot of problems with some of the medications that they were distributing. That's why some tribes have moved to other MAT medications, because those have been seen to help them more so. So let me see. So we have to look at not only what they're not comfortable with, but also how it affects people, because it's not always going to be the same. A lot of, but then again, there are also tribal medicine people who do not agree with some of the medications, because in the past, when they go to like a doctor to something for cancer or something like that, they take a medication that isn't always helping them. But that means that while they're taking certain medications or going through certain kind of treatments, the medicine men are not able to treat them, because the medicines that they know to help them are actually being destroyed by that. So I hope that helps.
Thanks, Sean. Appreciate that. So let's take a look at some counseling theories and different practices associated with these. There are numerous ones that I know that many of you are familiar with, so we're not going to spend a whole lot of time, but I just wanted to introduce these. Just some behavioral therapies, cognitive behavioral approaches, contingency management is a big one. Brief screening, intervention, referral to treatment, the ESPERT. Many of you probably have utilized this. It's a great stepping stone into making referral into a formal treatment or a formal referral process. RET, motivational interviewing, of course, has been very popular in the last 15, 20 years, and stages of change in conjunction with that or separate from that. And then also the medicated assisted therapies associated oftentimes with alcohol or opioids. So some things to consider regarding behavioral therapy. I know many of you know this, so this is a review. But behavior is learned, therefore it can be unlearned, and I think that sometimes can be challenged. Yes.
Our view now is just of like a button that says resume slideshow.
I must have done it again. Is it back?
Can you? There we go. Now it's correct.
Is it back? What did I do? I must have hit it. I don't know. I got too many buttons here, folks. Yeah. Somebody take some of these buttons away. New behaviors can replace old ones. Thanks for letting me know that. And then less interested in behavioral theories are less interested in cognitive emotional states and believe that behavior represents these sort of learned habits. And we can see how that may apply to, there it goes again. Yeah, I think it's because I have two I have two. I'm just going to close this one out. I just can't see my notes on this other one. Oh boy. There we go. Yeah, when I try and advance these other slides, it seems to shut this one off. So I'll be careful. And let's keep moving. Behavioral theory of conditioning. So they're really broken down into two different sort of modes. One would be this classical conditioning that I know we're familiar with, as far as the Pavlov's dogs and things of that nature. Ah, dang it! I don't know what to do here. Let me. I can't advance those slides without. It's really strange. Okay. So classical conditioning and then operant conditioning. Those are the two sort of behavioral theorists different approaches, or looking at this behavioral theories from these two perspectives. This idea, this classical conditioning, the Pavlovian dogs, and then operant conditioning refers to an association between a voluntary behavior and a consequence. And I think these can play out in many different ways, and especially within the substance use disorder population or the mental health disorder populations that we work with in a clinical setting. Motivational incentives and contingency management. Again, this is another approach, I think, that that oftentimes is. It's not going to let me. I'm just having a hard time, Kate. I can't seem to see my notes. I did something earlier that I don't know where I closed something. Let me. Doggone it. Let's see if I can. Sorry about this, folks.
So, Steve, earlier when you shared, it showed us like the screen that shows your notes.
Yeah.
And so usually you might just have to like switch which
there we
screen
go.
you're sharing with
How
us.
about that? Is that better?
Okay.
Can you guys see
it
that?
Looks good here.
Okay, good.
Yeah, we can.
I think I got it back to the way I had it. I think I closed something and then couldn't get it back open. So motivational incentives again are another way we see this approach utilized, oftentimes offering small rewards or incentives to patients for making changes during their treatment. There's some controversy connected to this, but it does have some evidence-based backing and has proven to be effective with certain treatment populations. Motivational incentive is equivalent to contingency management, providing reinforcement for healthy behaviors. So offering small prizes or small monetary rewards for example, for providing a negative urine screen, or for attending all of your treatment groups for a subsequent number of weeks. Variety of things that could be provided randomly as rewards to patients involved in treatment. There's a lot of information out there about motivational incentives and contingency management if you're interested in learning more about that. And I'm sure some of you have used this in one form or another within your clinical practices. So let's look at CBT approaches. This really combines sort of behavioral therapy and also cognitive therapy. Just to think of it as, I think of CBT as really connecting thoughts and emotions with behaviors, and simply put, cognitive behavioral therapy attempts to help patients recognize, avoid, and cope. And this, I think, sometimes can be extremely foundational for someone who perhaps has learned from an early age to use substances as their primary means for coping or dealing with trauma or grief or loss. Yeah, and as I said, I think CBT approaches, I think of them as helping patients connect their thoughts with their behaviors in order to raise awareness and promote this idea of positive change. Relapse prevention, in terms of the cognitive behavioral approach, I think there's some things to consider here. Identifying high-risk situations, this is pretty basic treatment sort of knowledge, but identifying high-risk situations, practicing coping skills, enhancing this idea of self-efficacy or locus of control, relapse reframed as these teachable moments. Oftentimes you would hear, we would say relapse is part of the recovery process. Sometimes it may allow you to learn and improve on something you missed maybe in your first treatment engagement. The challenge is positive alcohol expectancies. In other words, I had patients that would say to me, well, Steve, everybody smokes pot. That's just the way it is. Everybody does. How am I going to have fun or meet people if I'm not smoking? That's an opportunity to maybe point out to the patient that, well, not everybody smokes pot. And then just lifestyle balance is also something you would look at in a cognitive behavioral relapse prevention dynamic. RET or REBT, sort of in summation, it's something happens to the patient has an irrational belief about the situation, and the patient has an emotional reaction to the belief. The clinician is really there to recognize these errors in thinking that led to the irrational belief, and then find alternative ways to reframe that and look at it in a different way. There's an example. Yeah, so you believe that law enforcement has it out for you, and that's really what you attribute your DUI or your OWI to. Let's look briefly at the stages of change model. This is the Prochaska DiClemente model, and I think the stages of change. I don't know how many of you are familiar with this, but they are applicable to a variety of different patient populations. I was trained to use them in the context of substance use disorder patients, but it really affords the clinician as well as the patient an opportunity to really identify where their readiness to change is and how that may change over time. We would use stages of change in conjunction with our ASAM criterion to help monitor and look for improvements or maybe setbacks in a patient's level of readiness to make changes. It also fits nicely with motivational interviewing, and I know that I could have a group of patients. I might have a patient in a pre-contemplative stage or several patients in a pre-contemplative stage. They could work with in a group setting, even with patients in a preparation, action, or maintenance stage. So there wasn't an exclusive readiness to change that prohibited patients from different levels of readiness from working with each other in a group setting. MI, again, I think this is motivational interviewing is something that many of us are familiar with. There are some fundamental components to this, and oftentimes operating in the spirit of MI sometimes is enough to really start to uncover some of the deeper meanings and the deeper effectiveness through different strategies and techniques. And I really think of motivational interviewing as using specific language and specific strategies to empower patients to make changes. And if they're not ready to do that, that's okay too. That my role is not to make them change or make them quit using, but rather to explore what that would look like and if they're ready. Very liberating both for the patient as well as the clinician. But here you can see, I know we're not going to spend a lot of time on this, but because we could spend an entire session talking about MI. But fundamental approach really rests in this notion of collaborating and then making suggestions and evoking the possibility and having that change talk. And then again, creating that sense of self-efficacy and that the patient has some say and some control in what's happening to them and where they want to go. But there are your four sort of principles: empathy, discrepancy, rolling with that resistance, or rolling with that the idea. I think they call it dancing with discord now or something. It's got a different title. We took the term resistance out because it seemed negative. But then supporting self-efficacy, or this idea of empowerment, that the patient has some say and control over what's happening to them. Again, clinicians commonly think that they already practice motivational interviewing, although that's not often the case. The spirit of MI sometimes can come out in what we're doing with patients, but really being trained in MI means being mindful of using very specific language and really using that consistently to promote and evoke change within the patient. We're going to keep going here. I'm going to try and get us back on time. Yeah, the SBIRT is we referenced this earlier, but it's really a fantastic it's really a fantastic tool, a brief screening tool that can be administered by non-professionals, or it can be self-administered, or it can be delivered by a professional in a variety of settings, whether it be medical or even in a primary care setting with a primary care physician. I'm sure some of you have utilized SBIRT in one form or another. Other theories worth mentioning: the social cognitive theory, healthy belief model, and social ecological model. All of these are interesting, and I also thought about the solution-focused behavioral therapy and the miracle question that's often used, in that approach. Look up miracle questions sometime. There's a lot of good short videos out there about utilization of the miracle question with your patient. So let's see if we can. Let's see what we're looking at for time here. Okay, we got to move. Behavioral health care, substance use, and mental health. So just to get kind of a visual, think of this idea of this integrated behavioral health care as in these sort of segments. And I think this is just an example, but think of mental health, substance use disorders, primary care, and then maybe gambling or some other issue related to the behavioral health integrated care system being involved in that milieu. And again, I want to go back to this idea. It's important that we see that a patient's substance use is not the problem. It's causing them problems. I'm not saying that it's not, but rather it's a sign or symptom of other underlying issues driving that substance use. Very important. This influenced how I connected with patients, and really helped me guide other clinicians learning about working with this population and treating them and connecting with them in a meaningful, purposeful way. So co-occurring disorders, what does this mean? I think that's something that is important. In medicine, comorbidity is either the presence of one or more disorders. The term dual diagnosis is often used, although I think the co-occurring has sort of replaced that, but it's still used in the vernacular. A dual diagnosis is still a term that's used, but think of it as a comorbid condition. So this could be, there's a variety of co-occurring issues. Chronic pain, grief and loss, trauma of some kind, number of different co-occurring or underlying issues that we can identify. It could be relationship issues, it could be financial or occupational issues, a number of things. Other ideas, think about other ideas. If we had a little more time, I might open up discussion for that on that topic. What are co-occurring disorders? Well, in sort of a clinical term, or if we look at criterion, we would think of the presence of at least two disorders, one being substance use disorder, the other being a DSM-5 mental health disorder, or it could be any one of these or something connected to that, or it could be another underlying issue that I mentioned earlier. But the characteristics of a co-occurring disorder: repeatedly cycle through treatment, emergency departments, detox, and other institutions, more likely to reoffend or to receive sanctions when not taking medications, or not in treatment, or experiencing mental health symptoms, or using substances. Even small amounts of substances may trigger reoccurrence of mental health issues or other comorbid or underlying issues. General assessment approach for co-occurring disorders. Well, we're going to utilize the ASAM criterion. There are sections for substance use disorders as well as mental health. This helps monitor progress, direct a level of care, and remember, it's going to be clinically driven rather than program driven. And it also just assess the significance of the substance use disorder. I was always a believer that I was very hesitant about making mental health, doing a mental health evaluation or assessment until the patient had detoxed fully and was at least stable from their substance use. But having that comprehensive or history of mental health and substance use symptom onset, analyze whether the mental health symptom occur only within the use of substances, so substance induced, and determine whether sustained abstinence leads to rapid and full remission of mental health issues. Characteristics of co-occurring disorders, we're going to continue. More rapid progression from initial substance use to higher levels of severity, poor adherence to medication, and the list goes on. We have there's quite a few components that we would look at for determining whether or not the substance use is really symptomatic to some of those other underlying co-occurring disorders. And again, we have there's quite a list of different characteristics, and some of these are attributed directly to specific mental health conditions or diagnoses, and others may be connected to medical conditions or trauma-based conditions. Co-occurring disorders in adolescence. I think it's important to note that 90% with lifetime co-occurring disorders had one mental health disorder prior to onset of substance use. 90%. Median age for mental health disorder is age 11, and onset of substance use is between 16 and 21. And I think it's important to note with onset of substance use, one of the markers I looked for was age of onset for first time of use. Really is a determinant for prognosis, or it can be a determinant for prognosis. So earlier the onset of substance use, the more likelihood there would be problems later on in young adult and adult life. Just kind of getting close here to the end. Evidence-based practices.
Yeah.
Yeah.
I think maybe we should actually pause here because we have a number of questions.
Oh boy, yes. Why do I have the feeling we're not going to make it through these slides?
we can always schedule a second part of this if we want to find the time for the rest of this. What's involved in the rest of the session. But I want to make sure that we get to some of these questions. People have some really good questions. So
that sounds good.
If that's okay?
Yeah, that sounds great.
All right. So let's see. Curious to know how improved service delivery works in rural areas or in cities where there are a lack of services.
Yes, I'm curious too. That has always been an obstacle where the services are available, but if you don't have transportation, or you don't have the right insurance, or you don't have the right connections or networking, you're really left out. And I think there are different components to some clinics. There may be in-home services, or like a case management component where the clinician or a recovery support person, a behavioral health aide, or someone could visit the person in their own home. But again, that takes resources and can be difficult to fit into a budget if the budget's already compromised. So that's it's a great question. We're blessed to have the ability to connect with people like we are now. But again, if they don't have access to basic internet or reliable signal, they really are isolated and sometimes forgotten. So that's a good question. I don't have a solid answer for you. I'm sorry.
Yeah, we've got a couple of kind of related questions. First one is just a comment, and then so I'll put these both together, and maybe you can respond to this together. One of the issues I've seen is that tribal behavioral health agencies don't have authority to prescribe, so the client has to be referred out, and this can create big-time obstacles.
Yeah.
And then another question kind of related to some of these same issues. What funds do you use to pay for motivational incentives, and how do you manage funds and rewards?
Yeah, well, the first comment, I think telehealth, can be one medium to work around that. If you have a nurse practitioner or access to an online physician, sometimes they can prescribe, but it can be tricky as well. The propensity for diversion or misuse of certain substances or prescriptions can always be a risk factor. The other question was what was that one pertaining to?
How to pay for motivational incentives.
Yes.
Managing funds.
I'm glad you actually mentioned that, because I know that the TOR, there's some money being set aside and offered through the TOR grantees, where they're trying to implement some motivational incentives, and sometimes it can be funds that are deemed discretionary, or what do they call it, decategorized funds. But you have to be careful. There's some really pretty strict guidelines about how much and what you can offer as incentives. So it can be a little tricky, and I would suggest probably talking to your administrator and then finding what resources are available. But there are some guidelines as well you have to follow in order to ethical guidelines and best practices for motivational incentives.
Okay, another question. This is going back to the stages of change model. Is pre-contemplation not thinking, or just has to be brought out of our subconscious?
Well, that's a great question, and I think part of I used to say that pre-contemplative stage of change, in the old days, you know what we used to call that? We would say, well, that patient's in denial. That patient is just in denial. And really, if you think about that, there's an element of truth to that, but we really don't use the term denial anymore. Plus, I always thought denial was a river in Egypt. God, thank you for setting me up for that, caller. I do appreciate that. But honestly, though, a pre-contemplative stage of change, by definition, means that the patient does not believe there's a problem. So why should I change? If I'm using alcohol and enjoying the benefits and getting my drink on and partying with my friends, and I pick up an ODub and I go into a treatment setting and somebody says, well, you need to stop drinking for the next 8 weeks, I'm going to probably not find that notion real pleasant. So it's hard to answer your question because each person brings with them a different set of perspectives on whether or not or how they would know. Sometimes I would say, I know you don't think that there's an issue with your alcohol or drug use, but how would you know if there was? What would be an indicator or a sign that something was that there was a problem there? And so it's hard to say. The idea though that I'm going to change something that I don't feel there's a problem is in and of itself problematic from a treatment perspective. So you really have to shift gears when working with pre-contemplative patients. Diagnostically, they probably are a mild or maybe even unspecified substance use disorder where they're not meeting full criterion anyway. So it's a tough population. I actually like that population because we can talk about what might happen, or we can talk about if they were to continue drinking and using, what that would be like for them. And sometimes that's what they need to do. Not everyone that comes through your door is going to go on to have lifelong alcohol and drug issues. Some will move through it, some will phase out of it and move on. Others will not. So yeah, I don't know if I answered your question, but it's a good question.
That reminds me of, I can relate that to like any other kind of decision to make a healthy choice in life. And
right.
One of the jokes that I always hear is like, people always kind of joke about like diet starts Monday, and I feel like when I hear that, I'm like, I want to always tell people about the stages of change that we have to like be loving towards our relatives who want to change or who are thinking about it, and not be judgmental of where they are in that process.
That's right. That's right. Well, that's true.
We've had a lot of really good questions and comments about adverse childhood experiences and historical trauma, and there's just been a lot of discussion going on here about including that into the therapeutic process, or and so Steve, I'm wondering if you can speak a little bit to how providers might include that, and whether it's part of assessment or other parts of the treatment process.
Well, yeah, in short, and Sean might have something to add to this as well, but I know that in short, any good comprehensive assessment, whether it's stated very bluntly or sort of subtly, is going to screen for any history of physical, verbal, or sexual abuse. And it can be sometimes difficult to broach that subject with a patient in an evaluation or assessment setting. And I think the historical trauma piece, I know, is something that in an assessment tool that's geared towards working with Native populations, a culturally adapted assessment better have a question about this or something pertaining to this, because I think it really it will really allow the clinician to adjust for the approach and the goals and that longer term treatment process and continuum. It's trauma is a tricky thing because it's not something that you can just treat and move on from. It's like post-traumatic stress. From my own PTSD, I've come to terms with the notion that it's not something that I'm ever going to be free of. But what will change is how I see it and how I choose to process and work through it. Thus less impacting my daily living and the quality of my recovery. So that's a great question. And historical trauma is something that I'm just scratching the surface on understanding and learning about through the help of Sean and others, in the Native community. So it's a great question. It's important.
Wonderful. Yes, I was just chatting with Ray Daw, one of our advisory council members and consultants too, about it just seems, we have had a number of different sessions that have covered historical trauma from different perspectives, but I think it might be time to put together a series with a number of different providers who can speak to that from a range of perspectives. So I appreciate people bringing that up, and it's really good to know that there's interest in that and people are thinking about it. So thank you all for your questions. I think we have one more question, and this might be more directed to the group, or if people have comments or experiences they want to share. But Hector asks, are people using protective factors like video capturing elder stories in native languages? I'm curious if others have other protective factors, cultural things that they use, that can help in prevention and that kind of thing. Please feel free to share those, and we'd love to see what kinds of things people include in their therapeutic process. But yeah, Steve, I want to, while people are sharing that, do you have any final thoughts you want to, we can end our session here pretty soon?
Yes. Are we going to try and pause and pick this back up? Is that what the plan is, then?
Yeah, I think we can schedule another date to do to cover the rest of this topic and make sure we get a good session on the MAT and pharmacotherapy, those things. So we can definitely add a session in September and look at that. So
that sounds great. Yeah, I guess we are at the bottom of the midpoint of the hour. So it's been really, really nice. I'm sorry I had some technical difficulties and wasn't able to monitor that chat quite very well, but great to see some familiar faces on. And I would just say, if you're practicing now, keep some of these concepts in mind, and maybe you already do, that really patient substance use is not the problem. It's just a sign or a symptom that they're struggling to find a better way to attach meaning and purpose to something that they've struggled with perhaps for a long time. And to take away their substance use is without offering an alternative, a viable alternative, I think is it's irresponsible on my part as a clinician. I have to offer them something, a substitute that will allow them to work through and process. So healing the spirit and the mind and the body are all connected. I used to say that to patients all the time. If you heal the body, the mind is more likely to follow. And if you heal the mind, the body also will respond. So it's all connected. I really appreciated everyone's time and attention. And yeah, Kate and I will figure out a time we can come back and talk a little bit about medicated assisted therapies and some of the other components related to that, some of the historical components. So thanks again for Sean being on, and others that I noticed, Doc Foster and others. Thank you. We'll have you fill out a brief survey at the end, and let's come back and we'll talk. We've got about 20 slides left. We'll come back and do this again maybe in September.
Wonderful. Thank you so much, Steve, and thank you for that wonderful teaching, and really appreciate all of the conversation happening and sharing. So yes, I hope you all join us soon for another session. Next week we have a webinar on the third in the series of Understanding Suicide. So that'll be next Wednesday at the same time. And like I said, I just shared a link to our storytelling session, which will be happening in about 30 minutes.
Yes.
So we'd love to have you join us for that. And please email me if you don't get our announcements for these events, and I will add you to our email list. So yeah, thanks again, and I hope you all have a great day and stay healthy, and we'll see you next time.
Take care, everyone.